I'm Dr. Brigid Freyne, and I'm a rheumatologist in Murrieta, California. As a rheumatologist, I treat all types of arthritis and autoimmune diseases, osteoporosis, and as well as some general internal medicine. Gout is a type of arthritis that I find most fascinating, most intriguing, because it's so simple to treat. There's such good treatments that can totally change a patient's life. A lot of them go undiagnosed for years, and a lot of them are not adequately educated on the course of this disease if left untreated. Most cases of gout are undiagnosed, untreated, and then of the people who are treated, they are usually managed by urgent care, emergency room, or primary care physician, and often they're not optimally managed. So I think as a rheumatologist, I'm better equipped to treat gout patients and explain it, educate the patient, and put them on the correct treatment to improve their life. Gout is a special type of arthritis. It's considered an inflammatory arthritis because the joint is inflamed. It becomes red and hot and very painful, and it's caused by a crystal. Under a microscope, there's a crystal that's pathognomonic for gout. It's needle-shaped in a certain direction under a polarized microscope. Technically, they break down a protein that we eat, and usually the kidneys excrete them. But in certain circumstances, the patient's kidneys do not adequately excrete uric acid, and this can be a factor of renal insufficiency. That means their kidneys are not working optimally. It can be a factor of coexisting medications, such as diuretics. Like the classic one is hydrochlorothiazide. It's a diuretic given for blood pressure, and it causes the kidney not to excrete the uric acid crystals. The joints attract an inflammatory cascade of neutrophils, a type of white blood cell, and it causes swelling, inflammation, and extreme pain. Gout is extremely painful. So usually it happens overnight. That is because the body cools, and gout crystals solubilize at cool temperatures quicker. It usually is in the extremities. The big toe is the classic because it's cold. The foot is far away from the core of the body. And at night, the whole body cools down and gout crystals precipitate, and the person wakes up with 10 out of 10 pain. Diagnosis of gout by literature, it's you aspirate the joint and put the fluid under a microscope and see the characteristic crystal. But because patients are in so much pain, they often don't let you near their painful joint with a needle. So I usually diagnose it by asking patients questions. Tell me about your pain. And I ask them specifically when it happens, how quickly it goes from 0 pain to 10 out of 10 pain. When did it start? How frequently does it hit you? How long is the intercritical period? How long are you between attacks? How often are the attacks? Are they getting more frequent? How long do they last? What do you do to make them go away? And then, of course, their comorbidities. Their age, their gender, their coexisting medications, all these play into their risk factors for developing gout and can help me ultimately determine if this is what they have. When it first starts, it's usually monoarticular. That means one joint affected at a time. And usually it's the big toe. So the most common affected is the big toe. The second most common is the arch of the foot. The third most common is the ankle. And the reason again for that is the temperature. So the foot is the coldest in the body because it's most distal from the heart. And it usually happens overnight because the body's cold. You're not moving, you're sitting, your temperature lowers, your metabolism has lowered. And that's usually where it affects. And the crystals deposit in the joints and cause an extreme pain, and the onset is from 0 pain to 10 out of 10 pain in 12 to 24 hours. So it happens, overnight, 8 hours. 90% of gout is caused by renal underexcretion of uric acid. 10% are rare circumstances where it's overproduction of uric acid, and those are patients who might be getting chemotherapy for bulky lymphomas, or they have rare genetic defects. So that's rare to have overproduction. Most of it is renal underexcretion, which happens in people who don't have perfectly functioning kidneys due to either normal age-related decline, or they might have medications that they're taking that decrease their renal excretion of uric acid. Tophi are lumps of palpable crystals that are found. They can be found anywhere on the body. The most classic location is the elbows and the toes. You can be on the knees, the patella. They can be on the feet. They can be on the fingers. And they're palpable lumps on the body. And we can see them, feel ones that are external, but there's ones that are deeper in the deeper structures that patients have untreated gout for years, and they erode into the bone and cause joint damage. So the idea is to bring their uric acid down low enough that the crystals aren't allowed to sit there. Get them out of the joint. If they're not in the joint, they can't cause pain, they can't cause permanent damage. And this can be easily found by the lab. If you aspirate the joint, send it to the lab for fluid analysis for crystals, they can easily see that, and that's your diagnosis. Obesity is definitely a risk factor for gout, and that's one of the proposed reasons why the incidence is increasing in our population. So it has to do with a turnover of purines, if there's a high caloric intake, and also high fructose corn syrup, which is increases the risk for gout, as does beer. Beer is the worst form of alcohol for gout because it definitely increases the risk for gout. Of all alcohol, beer is the worst, and wine is the least likely to provoke a gout attack. There's lots of patients that have a genetic predisposition. There's certain ethnicities that are more prone to gout, such as Filipinos have a very high rate of gout, and it's something in their genetics where they have a high uric acid in their body and they're more prone to gout. So, but in most people, it is a function of the renal decline. Men are more likely to develop gout at a younger age than women. The reason for that is estrogen is uricosuric, but after menopause, men and women have the same incidence of gout. So we know that estrogen decreases a person's risk for gout. That's why it's essentially unheard of in premenopausal women, whereas postmenopause, the incidence is equal in men and women. The patients with gout figure out their risk, their correlations, what triggers their gout. And often I'll have patients that say they went to a all-you-can-eat seafood buffet, and that's the next day they develop gout. So it's very common. They know what triggers it, or they overdid it on a summer weekend and had lots of beer. So patients definitely know, they figure out the triggers because gout is so very painful that they can figure out what to avoid to avoid the painful gout attack. So beer is a trigger, high fructose corn syrup. So a can of beer has the same risk factor as a can of non-diet soda as far as provoking gout attacks because of the high fructose corn syrup. High purine loads, seafood, meats, a large quantity of intake of that will provoke a gout attack. Dehydration. That's why patients in the hospital being operated on often have developed gout because they're dehydrated. Trauma to the foot. Let's say they go for a run. The trauma to the foot, that might trigger a gout attack. There's a lot written about dietary involvement with gout, but over time we're becoming more cognizant of the fact that gout isn't 100% caused by diet. I have many patients who come in and say they understand that they have been diagnosed with gout, but they're going to do it by diet alone and not take the medicine I prescribe. And I have to discuss with them that diet has something to do with it, yes, but it's not the answer. Because if they eat the perfect gout diet, they would only lower their uric acid by 1.0 milligrams per deciliter, and that's not enough to control their gout. In addition, the perfect diet for gout, I believe, would cause malnutrition because they would have to take no seafood, no meat, and no beans, and it's very restrictive. They would just do low-fat dairy products, which does lower uric acid. But again, I tell the patient that it's not their fault that they have gout because it's not what they eat. It's more how their kidneys are working as well as other medicines they might be on. Of course, I encourage them to lose weight to possibly decrease their incidence of gout, to eat healthy, more low-fat dairy, more vitamin C, because vitamin C increases the renal excretion of uric acid. But I reassure them that it's not 100% their fault. Patients think it's their fault. They can cure it with diet, and that's not the case at all. I've never seen a person cure their gout with diet alone.